Hello, good evening, everyone. It's 6 p.m., so I would like to get started with this amazing webinar we have today of ANCA-Associated Vasculitis. And it's my honor to introduce to you our speaker. It's Dr. Odler. And a little bit of his background. He did his medical studies and his PhD study in Budapest, Hungary. And afterwards, he did his residency and is now a nephrologist at the Medical University of Graz in Austria. And he has also been to the University of Cambridge for a postdoc. And he will tell us today more about ANCA-Associated Vasculitis, and he will give us some tools on how we could decide whether or not plasmapheresis is a good treatment for our patients. So thank you for having the time to tell us more about ANCA-associated vasculitis, and the floor is yours. I'm very happy that you're here tonight.
Thank you very much for this very nice introduction. Dear colleagues, I will share my screen with you right now. I hope that you can see it.
Okay. Yes, we can.
So, perfect. Okay. So then I would start. Dear colleagues, first of all, thank you very much for the invitation. I am quite happy to be here today to discuss this quite interesting topic and one of my favorite topics in medicine, the ANCA-associated vasculitis. So in the next approximately 30 minutes, I will try to give you a quite comprehensive overview on the pathophysiology, diagnosis, and cure and treatment standards of the disease. Before starting, here you can see my disclosures, and here is the agenda of my today's talk. So at the beginning of the presentation, I will talk about the overview of ANCA-associated vasculitis, including clinical classification and pathophysiology. Then I will more focus on diagnostic challenges and cure and treatment approaches, including different immunosuppressive agents. And I will also focus on adjunctive treatment options like plasma exchange, and then I will move on to more to the holistic treatment approach of the disease, including the treatment and prophylaxis of infections and the management of cardiovascular risk. At the end of the presentation, I will be very happy to take your questions and discuss these topics with you together. So as you all know, ANCA-associated vasculitis is a multi-system autoimmune disease that is characterized by inflammation of blood vessels, endothelial injury, and tissue damage. Most of the patients are presenting with a severe organ or life-threatening disease at the first presentation, and the disease has a relapsing, remitting nature that is necessitating an effective immunosuppressive treatment. So the most widely used classification system for systemic vasculitis is that defined at the 2012 International Chapel Hill Consensus Conference, which stratifies vasculitis according to vessel size. And as you can see here, the ANCA-associated vasculitis is divided into three clinical diseases. The first one is the microscopic polyangiitis, so MPA, the granulomatosis with polyangiitis, GPA, and the eosinophilic granulomatosis with polyangiitis, so EGPA. Each of these conditions is commonly associated with a circulating ANCA with the major target antigens identified as PL3, so proteinase 3, and MPO, so myeloperoxidase. If we are talking about these entities, then we have to mention that one of the current controversial issues in ANCA-associated vasculitis is the definition of disease based on clinical phenotype like GPA or MPA, because there is a significant overlap in clinical features between these two diseases. It has been suggested that ANCA-associated vasculitis should be classified according to ANCA specificity, like PL3 ANCA disease and MPO ANCA disease. because the knowledge of this ANCA subtype is more relevant than the pathogenic, but the phenotypic diagnosis like GPA or MPA when predicting, for example, clinical presentation, disease course, or treatment responses. If you take a look at the clinical presentation of these patients, then you can see that most of the patients with PA3 or MPO ANCA-positive vasculitis have distinct and substantial differences in the clinical presentation. For example, those with PA3 disease have a more likely granulomatosis features and a higher relapse risk as compared to the MPO patients with a lower relapse risk but with higher mortality rates. In addition, we also have to mention that genetic studies segregate more closely with ANCA specificity than clinical phenotype. And if we are talking about PA3 or MPO ANCA vasculitis in terms of the phenotypic diagnosis, then we can say that PA3 ANCA is most commonly associated with GPA, while MPO ANCA is most commonly associated with MPA or renal limited vasculitis. The pathophysiology of the disease is quite complex and unfortunately not fully understood. Nevertheless, there are two major components that I think very important to discuss. That is the role of the ANCA antibodies and the neutrophil activation, and the other one is the activation of the complement system. Why is it important to talk about these two components? Because I think if you understand these two components of the pathophysiology, then you will be able to better understand the cure and treatment approaches that we use in the daily clinical practice. So if we are talking about ANCA antibodies, then we can say that ANCA binding to this antigen, to the antigens, to proteinase 3 and MPO, so to myeloperoxidase on the cell surface that results in neutrophil activation and release of different factors that are normally secreted in the primary granules of the neutrophils. It can be triggered by infection or other environment stimuli, and binding of ANCA to these autoantigens results in activation of neutrophils, which adhere to vascular endothelium, and in addition leads to neutrophil degranulation with the release of reactive oxygen specials, proteases, or nets, damaging the endothelium. In addition, chemokines and tissue deposition of PA3 or MPO result in the recruitment of autoreactive T cells and monocytes that augmenting the tissue injury as well. But the binding of these ANCA antibodies to their autoantigens, so to PA3 and MPO, leads also to the activation of the complement system. And in this activation, the membrane attack complex plays a limited role, but generation of the anaphylatoxin C5a attracts further neutrophils, and on binding to the cell surface, C5a receptor, which is also called CD88, enhances neutrophil priming and activation, resulting in the formation of an amplification loop, which is also promoting the inflammation. So it sounds quite complicated, but the most important task what you have to understand that the production of ANCA antibodies leads to binding to its autoantigens and to neutrophil activation and activation to the complement system that leads to inflammation in different tissues like in the kidney or lung or in the skin. The diagnosis of the disease is quite challenging, as most of our patients are presenting with non-specific symptoms at the beginning of the disease, like with arthritis, myalgia, or unspecific respiratory symptoms or skin lesions. The peak incidence of the disease is over 60 years, so it mostly affects elderly patients. Nevertheless, we we also see younger patients affected by ANCA-associated vasculitis. If diagnosing the disease, then systemic approach is warranted. For that aim, you can use the so-called Birmingham Vasculitis Activity Score that can help you to assess the organ involvement on the disease and get some information of the activity. Of course, this score system also have limitations, and some organ manifestations are not captured on this activity score. So you also have to think about the disease as a complex process and complex diagnostic approach. Of course, the most important first step in the diagnostic process is the antibody testing. For the antibody testing, you can use two different methodologies. The first one is the indirect immunofluorescence assay, or IIF, what you can see here, followed by an ELISA testing, by a high quality antigen specific assay. There is a new consensus paper, it has been published in 2017, that says that that high quality antigen assays for PL3 ANCA and MPO ANCA should be used instead of the IIF methodology if you are testing for ANCA antibodies. You also have to think about the fact that approximately 5 or 10% of the patients with systemic vasculitis do not have antibody positivity. So this is the so-called ANCA-negative pouchy immune vasculitis. And if you are testing for the antibodies, that you also should not forget about testing the anti-GBM antibody, as the presence of these antibodies needs an completely other therapeutic approach than in those patients only with ANCA antibodies or without double positive disease. This issue I will discuss later on more in detail in my presentation. But of course, the gold standard of the diagnosis is the biopsy, so the tissue biopsies. This is indicated in case of diagnostic uncertainty, kidney biopsy in case of hematuria or proteinuria or impaired kidney function should be done. We have to note, and it has to be noted, that other target organ biopsies are often non-specific and require experienced physicians. For example, biopsy of nose tissue often reveals unspecific necrotic mucosa and sampling error, and can lead to a delayed diagnosis of the disease. I would suggest to you, in cases of symptoms unclear origin, you should always think about ANCA-associated vasculitis, and you should test the ANCA antibodies. But if you do that, then you have to think about the fact that ANCA antibodies might be false positive as well. In these cases, you often see low titers of this antibody or both positivity for MPO and PL3 antibodies. That is the so-called double positive ANCA. This can happen in many infections, as you can see here in the table of the right side of this slide, or in the case of drug-induced vasculitis, or in other autoimmune, systemic autoimmune diseases or kidney diseases. And why is it important to diagnose ANCA-associated vasculitis as soon as possible? We know it from large clinical trials and epidemiological studies that unfortunately our patients with ANCA-associated vasculitis are facing a much higher mortality rates as compared to the general population. And we also know that infections and impaired kidney function, as well as cardiovascular complications, are strong predictors of early mortality in this patient population. population. You can see on this figure that infections within the first 12 months are leading to very high mortality rates as compared to those patients who had no infection complications. And similarly, in those patients with severely impaired kidney function, the mortality rates are much higher. And this is important. Still, a lot of patients, so up to 60–80% of our patients have kidney involvement, as you can see here. It can be different in case of MPO or GPO or PA3 or MPO ANCA-Vasculitis, but still over approximately 60% of all patients. Other organ involvements are also important predictors of the mortality, like diffuse alveolar hemorrhage is also belongs to these organ manifestations, and it can come up to 20% in all of our patients. So this is also important if we are discussing the treatment of this disease. If we are talking about kidney involvement in ANCA-associated vasculitis, then I think it's very important to mention the role of the histopathological changes in our patients. And if you discuss with the nephrologist this disease, then you will understand why I say it. There is a quite important study that has been published in 2010, what you can see here by Annelies Berden and her colleagues. The authors in this study divided the patients based on their histopathological changes in the kidney into 4 different groups. The patients who had more than 50% globally sclerotic glomeruli, they belonged to the sclerotic class. Patients with over 50% of normal glomeruli belong to the focal class. And in those patients who had cellular crescents with more than 50%, they belonged to the crescenic class. And they also established a 4th group, which is the mixed class, consisting patients with a mixed proportion of these changes that I mentioned earlier. But they found, and I think that's striking, that the renal survival of these patients is depicted according to the 4 histologic categories. And as you can see here, the sclerotic category is associated with the worst kidney outcomes as compared to those with the focal or crescenic changes, where the renal survival at 1 year is much better. But now I would like to switch to the treatment approaches of ANCA-associated vasculitis and then discuss these histopathological changes more in detail if we discuss the distinct immunosuppressive agents or plasma exchange. So if you take a look at this therapeutic algorithm, which is from the Odler recommendation that has been published in 2022, then you can see that we can divide, if we talk about the treatment mechanically, then we can divide the treatment into 2 phases. The first phase is the so-called induction treatment phase, where our aim is to achieve rapid and effective control of disease activity. For this aim, rituximab, cyclophosphamide, avacopan, and glucocorticoids are commonly used, while methotrexate or mecofenolate mofetil can also be considered in some specific cases. Nevertheless, rituximab or cyclophosphamide in combination with glucocorticoids or in some cases with avacopan are the most commonly used treatment options. In the case of organ and life-threatening disease, the Odler guideline recommends the use of plasma exchange, especially in patients with rapid progressive glomerulonephritis. If the disease activity is controlled after the induction treatment, then we are coming to the second phase of the treatment, which is the so-called maintenance treatment. During this phase of the therapy, the aim of our treatment is to maintain control of the disease activity. In the most cases, it should be done for at least 24 or 48 months, but it can be longer according to or according to the clinical characteristic of our patients. Important to mention that avacopan should be stopped after 1 year after therapy initiation, because there are no long-term data on the use of avacopan after 1 year. If the patients are relapsing during the maintenance treatment, then the induction therapy should be done again. I will discuss with you the guidance of the maintenance therapy later on as well, because it's not always so easy. Some patients are relapsing, some patients does not maintain control of the disease activity, and some adjustment of the treatment can be necessary. So here I try to summarize all of the important landmark studies in the treatment of ANCA-associated vasculitis. And as you can see, this is a quite changing landscape. At the beginning of the 2000s, therapy options based on cyclophosphamide or mycophenolate mofetil, azathioprine or methotrexate were done, which was followed by studies. Here you can see these studies marked by green that were focusing more on the effectivity of rituximab in the treatment of ANCA-associated vasculitis. And 2 years earlier, the Advocate trial was published that investigated the efficacy of avacopan, that is a C5a receptor antagonist. I will talk about this study later on as well. And then I also marked 2 trials on plasma exchange that can be also important if you consider adjunctive treatment in your patients. So I don't want that you are sleeping during my presentation, so I won't talk about all of these studies, but I want to highlight some of them for you, just for your understanding. Why do we use rituximab, cyclophosphamide, avacopan, or plasma exchange in the treatment of ANCA-associated vasculitis? So let's start with the remission induction treatment and the main studies that has been performed for this aim. The RAVE and the rituximab trials were, in my opinion, the 2 most important studies that showed us that the use of rituximab is non-inferior to cyclophosphamide, and it can be used in the induction treatment of patients with systemic ANCA-associated vasculitis, or in those as well with ANCA-associated vasculitis related glomerulonephritis. What was the difference between these 2 studies? So the RAVE trial, both of these studies were published in 2010 in New England Journal of Medicine in the same issue of the journal. And what was the difference? So this is why I asked this question. So the RAVE trial was the bigger trial involving almost 200 patients with relapsing or new onset disease, and were introduced to either receiving cyclophosphamide induction therapy followed by azathioprine maintenance therapy, as compared to rituximab remission induction followed by rituximab or azathioprine maintenance therapy. The rituximab trial involved less patients, up to 44 of them, but all of these patients had a severe and new onset disease. And the huge difference was, or the significant difference was, as compared to the RAVE trial, that in the rituximab trial, the patients received cyclophosphamide induction therapy followed by azathioprine, and were compared to those receiving combined rituximab and cyclophosphamide followed by rituximab maintenance therapy. And what we saw and what we can say, that also the use of combined rituximab and cyclophosphamide induction treatment can be considered, especially in those patients who had severe disease with severe kidney involvement. We also learned that rituximab should be an important part of the induction treatment in patients with relapsing and non-severe disease. We also saw that reduced glucocorticoid dosing is not so bad and can be considered. That was in 2010, and the topic of glucocorticoids is quite important, so I think we have to talk about this topic more in detail later on. What is avacopan? Avacopan is a C5a receptor antagonist, and if you are thinking back on the complex pathophysiology, what I mentioned at the beginning, then you now understand why I mentioned that the complement system is quite important in the treatment of ANCA-Associated vasculitis. So this is avacopan is a C5a receptor antagonist, which has been tested in the Advocate trial. The Advocate trial was published in 2022 in New England Journal of Medicine, and showed that patients who received avacopan had a lower risk of relapse as compared to the patients who received standard of care treatment. We also saw in this study that the kidney function of the patients receiving avacopan showed a better increase within the first year after treatment initiation. But one of the most important advantages of the Advocates trial was that the glucocorticoids were stopped after 20 weeks of treatment, which is quite important because, as you all know, the use of glucocorticoids are associated with many different complications, like metabolic changes or infections, which is an important mortality predictor in our patients' population. Just some extra information on avacopan. It is part of the induction therapy already. You can give it up to 1 year, as I mentioned it earlier, and there is no dose adjustment necessary for older patients and in those with impaired kidney function. There are some contraindications as well, like in pregnancy, and if you are using statins, that you should stop that during the treatment with avacopan, because there can be a significant interaction between these two drugs. And then switching to glucocorticoids. So I tried to mention it at the beginning of my presentation that infections are one of the most important mortality predictors in this patient population, and glucocorticoids are one of the most important contributors to develop severe infections. And in the last years, we learned a lot about the use of glucocorticoids in the treatment of AAV. Two major trials, the PAXIVAS trial and the LOVAS trials, used or compared to the use of standard and reduced glucocorticoid dosing and found no significant differences in terms of the primary outcomes of these trials, which means that reduced using can be considered in our patients, and you should not be afraid using less glucocorticoids. Even if you consider the results of the Advocate trial, where the glucocorticoids were stopped after 20 weeks of treatment, and the outcome was better in these patients who received avacopan. So if you consider avacopan in the treatment of your patients, then you can stop the glucocorticoids very early. But otherwise, if you don't have this option, or if you don't want to consider avacopan, then you still should use reduced glucocorticoid dosing as well. And in this case, we suggest to use the protocol of the PAXIVAS trial, or you can also consider the protocol of the LOVAS trial. So what about the maintenance therapy? I mentioned you that the key component, the key immunosuppressive agent in the maintenance therapy of ANCA-Associated vasculitis is rituximab. There are different studies investigating the role of this agent in the maintenance therapy. One of the studies that has been published in 2023 is the Ritaceram trial from Cambridge that involved 188 patients with ANCA-Associated vasculitis with a relapsing disease. All of these patients received rituximab remission induction followed by rituximab or azathioprine maintenance treatment. What we saw in this trial that the use of rituximab was superior as compared to the use of azathioprine. So what we learned in the last time that rituximab should be used as a first-line therapy in the maintenance treatment. It can be given up to 2 or 4 years, but there is a huge difference in this indication because our patients are also different. I can't tell you how long you should use the rituximab in your patients, but and it should be based on an individual decision making, incorporating the clinical characteristic of the patients like comorbidities, earlier relapses, or the biomarkers that you can measure during the disease phase. Nevertheless, you also have to think about that you should not decide on the use of rituximab according to CD19 positive B cells or ANCA antibodies. It's also important to mention that the use of rituximab can lead to hypogammaglobulinemia, which can also be associated with infections. So immunoglobulins should be determined if you use rituximab in your patients. As I told you, individualized treatment approaches are important. The main recent studies from France helped to understand these individual approaches better. What we learned from these studies was first that rituximab is superior to azathioprine in terms of relapse rate and survival at 28 and 60 months as well, so after 5 years. Individual therapy management, according to ANCA antibodies and CD19 B cells, showed no difference. So if you are using rituximab, then you should not use ANCA antibodies and CD19 B cells to drive your therapy. And what we also saw that longer treatment interval are recommended in patients with high risk of relapses, like in those with PR3 positivity or earlier relapses. And then I would like to change to the adjunctive treatment options and talk about plasma exchange in the treatment of ANCA-associated vasculitis. So what is the relevance of plasma exchange in this disease? We all know that the ANCAs are pathogenic and the rapid reduction of their levels makes sense from a pathogenetic standpoint. Plex is basically capable of reducing antibodies and of plasma-enduring complement factors that we know that they are important players in the treatment of ANCA-associated vasculitis. If you take a look at the current recommendations, then the online recommendations says that plasma exchange may be considered as part of the treatment to induce remission in GPA or MPA for those with a serum creatinine over 300 micromole due to active glomerulonephritis. And it has a quite high level of evidence with 1A with a B strength of recommendation. On the other hand, this guideline says that the routine use of plasma exchange to treat alveolar hemorrhage in these patients is not recommended, also with a relatively high level of evidence. There is a quite difference between the KDIGO and quite significant difference between the Euler and KDIGO guidelines, because KDIGO guidelines still say that consider plasma exchange for patients with severe kidney involvement. Nevertheless, they also say or recommend that these treatment options can be considered in those with diffuse alveolar hemorrhage who have hypoxemia. And to understand these recommendations, I think it's important to talk about the two most important randomized control trials performed using plasma exchange. These two trials were the MEPEX trial and the PEXIVAS trial, as I showed you earlier, as we saw this timeline figure. So what is the MEPEX study? The MEPEX study was performed in the early 2000s and has been published in 2007 in JASN, so in the Journal of American Society of Nephrology. The study involved 137 patients with severe kidney involvement. So here you can see that all of these patients who were involved into this study had a serum creatinine over 500 micromole per milliliter. One of the patients, so one group of the patients received intravenous methylprednisolone, and the other group 7 sessions of plasma exchange. The baseline therapy was cyclophosphamide, orally administered. We don't really do it anymore, or followed by or in combination with oral prednisolone. One of the most important advantages of this study was that we have histological data in almost all cases. And if you take a look at this histological data, then you can see that almost 60% of the patients, or over 50% of them, had Kreskin changes. And if you think about this figure that I showed you earlier, that you can understand that this is quite important, because these patients have a higher opportunity to have a better renal outcome at 1 year. The chronic changes in these kidney biopsies were quite moderate. And what the study found, that the use of plasma exchange led to better kidney function recovery and also survival rates after 3 months and 12 months of therapy. After the MAPEX trial, meta-analysis was performed and found that there is no difference in terms of all-cause mortality between PLEX and no PLEX, but there is a lower risk of end-stage kidney disease if PLEX was used. Nevertheless, if you take a look at the data of this meta-analysis, then you can see that most of the patients were involved from the MAPEX trial, and all of other studies were small randomized control trials. So the question was whether can we use plasma exchange in a more extended indication as well, so in patients with less severe kidney involvement. And for this reason, the PEXIVAS trial was set up. And by now, this is the largest randomized control trial in ANCA-Associated Vasculitis, involving 704 patients with a severe disease defined by an eGFR under 50 milliliters or lung hemorrhage. The study had a 2x2 factorial randomized trial and aimed to investigate the efficacy of adjunctive PLEX in addition to standard of care immunosuppressive treatment, and the efficacy of two different glucocorticoid regimes, the standard and the reduced dose. And this is quite important because we learned a lot from this study, not only on plasma exchange, but also on the use of different glucocorticoid dosing. And these results were quite striking in 2020, and I think many centers changed their practice on the treatment of ANCA-associated vasculitis after seeing these results. So the PEXIVAS trial showed us that the use of plasma exchange did not result in better outcomes in terms of this composite endpoint of death or end-stage kidney disease after median duration of follow-up of almost 3 years. We also saw that the use of reduced glucocorticoid dosing as compared to the standard dose did also not result in differences in terms of this composite endpoint. That's quite important because it showed us that the use of reduced glucocorticoid dosing is not dangerous. We can do that in our patients. But if we are coming back to the topic of plasma exchange, then I ask the question whether it's okay to accept this result and do not consider plasma exchange anymore. Because if you think about the working mechanism of plasma exchange, then you have to consider that this is an immediate measure, and I am not sure whether long-term changes can be seen if you use plasma exchange at the beginning, as you can see here, because the curves are dividing at the beginning of the treatment. And this is why I would like to talk about this topic a bit more in detail. So here is just a comparison between the MAPEX and the PEXIVAS trial, and what I wanted to show you that the huge difference is because the results were different. MAPEX showed us that it helps, PEXIVAS showed that it doesn't help. The main difference was that the MAPEX trial involved patients with more severe disease, like the PEXIVAS trial, while the PEXIVAS trial patients with less severe disease. And of course, there were differences in the study designs as well. But we also learned from the PEXIVAS trial that there was no difference in terms of end-stage kidney disease at 1 year between the intervention groups. However, we have to consider that the outcome of kidney failure may be insensitive to the effects of plaques on kidney function, and how the effects of plaques on kidney function over time change remained uncertain. So this was the reason why we performed a post-hoc analysis on early renal response using data from the PEXIVAS trial. And what we found, and it's quite striking, that the mean eGFR change from baseline was higher in the PLEX group as compared to the no PLEX group at weeks 2, 4, and 8, but did not differ at any later predefined time points. We also determined some more primary outcomes, and what we also saw that the recovery of kidney function that was defined as a change of at least 15 milliliter per minute in eGFR was also higher in those patients who received plasma exchange. And of course, I am quite sure that you are asking the question whether it makes any sense to consider these small differences at the beginning of treatment initiation. So due to this reason, we also performed an association analysis, and we found that these changes, what I showed you earlier, are associated with a better end-stage kidney disease risk outcomes at 1 year after therapy initiation. So this data showed us, or I think shows us that plasma exchange still can be considered in patients with severe kidney involvement. Nevertheless, there are also some limitations of this analysis that I have to mention. For example, that we haven't had the histopathological data from these diseases. We haven't had data, for example, on proteinuria or hematuria that are also important predictors of end-stage kidney disease outcomes. So this is something that we also have to mention and consider if we are discussing these results. There is another post-hoc analysis of the PEXIVAS trial on alveolar hemorrhage that has been published 1 year ago in American Journal of Respiratory and Critical Care Medicine. In this study, the authors involved 61 patients with severe diffuse alveolar hemorrhage from the PEXIVAS trial, and take a look at the outcome on those who received plasma exchange or not. And what they found that 10 patients, so up to 30% of them in the control group and 20% in the PLEX group, died within the first year of follow-up because mortality was here the primary outcome. And they did not find any significant differences, statistically significant differences in terms of this outcome. Nevertheless, if you take a look at this graphic, that you can see that the IQR is quite width, and it goes to the direction favoring PLEX. And if we are discussing this topic, and we say that we would like to perform another randomized control trial investigating only this question on alveolar hemorrhage in these patients regarding the use of plasma exchange, then the recruitment of 312 participants based on the PEXIVAS criteria would be required to prove whether the addition of plasma exchange has a benefit in such a scenario or not. In other words, it would mean that close to 3,600 patients with severe ANCA-Associated vasculitis would undergo screening to randomize an accurate number of patients into such a trial. And I assume that there is nobody who will perform a trial like that. This is the last slide on the topic of plasma exchange, but I think this is quite important if you are managing patients with ANCA-Associated vasculitis. Some of the patients presenting with the concurrence of both ANCA and anti-GBM antibodies. It can happen in about 10% of the patients, and this is the reason why I said at the beginning of my presentation that you always should perform anti-GBM assays as well if you are diagnosing ANCA-associated vasculitis. If this so-called double positive disease is the case, then the use of plasma exchange is mandatory. So these patients need an aggressive and highly dosed immunosuppressive treatment at the beginning in combination with plasma exchange. So in this case, please consider plasma exchange. So switching to the topic of infections. Another important learning from the PAXIVAS trial was that plaques leads to an increased incidence of severe infections in patients with ANCA-associated vasculitis. But what we also learned that the reduced dose glucocorticoid regime was associated with more than 30% reduction in serious infections at 1 year. I also have to mention that this difference in terms of plaques was not significant in the PAXIVAS trial. And if we are talking about severe infections, and these are some data from the RAVE trial, then we see that that in most of the randomized control trials, the incidence rate of the infections were actually quite low. So, for example, in the case of the RAVE trial, approximately 12% of the patients had a severe infection. Nevertheless, we should not forget that the definition criteria are quite strict in these cases. So severe infections are mostly defined by using intravenous antibiotics, admission to the ward due to infections, or death due to infections. It is, of course, differentiating between the different trials that these are the main features that mostly are used when defining severe infections. So, but what we saw in this trial, that most of the infections were respiratory ones. And this is what we also see from other clinical trials and clinical studies. So respiratory infections are one of the most common infections in these patients. The severe infections are happening often in the early phase of the disease, as you can see here, and it's influenced by different demographic and patient-related factors like comorbidities or sex of the patients or the extension of kidney involvement. We performed the post-hoc analysis of the RAVE trial looking for predictors of serious infections. And one of the most striking results what we found was that the use of low-dose antibiotic treatment with trimethoprim sulfamethoxazole was associated with lower risk of any kind of severe infections, independently of the induction treatment used by rituximab or cyclophosphamide. If we are talking about prophylactic measures, then we should not only mention the prophylactic antibiotic treatment, but we also think about the vaccines as well. This is a quite important topic at the moment, especially after the COVID pandemic. And I think to discuss these options and to think about these options for your patients is quite important regarding influenza, hepatitis B, varicella zoster virus, or pneumonia vaccines. The last thing what I wanted to mention you, that is the cardiovascular risk management in ANCA-associated vasculitis. I mentioned to you at the beginning of my presentation that these patients are facing a high mortality risk, and one of the most important predictors next to the infections and kidney involvement are the cardiovascular comorbidities and complications. So what I would recommend for you, don't forget to identify and register this risk at the first presentation in your patients. Screen for and treat of arterial hypertension, hypercholesterolemia, diabetes, and arteriosclerosis. And you should talk with your patients about smoking cessation, but you can also consider that is the rapid steroid tapering, especially if you are using avacopan. So it has been a bit longer than I expected, but as a summary, I would say that ANCA-Associated vasculitis is a systemic autoimmune disease with a relapsing remitting nature that necessitates a quick and effective disease control. It is a diagnostic challenge, and you should think about it and try to diagnose it as soon as possible. Glucocorticoids, rituximab, and/or cyclophosphamide, as well as avacopan, are cornerstones of the induction treatment. Rituximab should be the first-line treatment if you do the remission maintenance therapy. Plex can be used after individualized decision making, but it is a must in double positive disease, and you should think about the cardiovascular risk management, about the infection risk, and you should use antibiotic prophylaxis and consider vaccination in these patients. So thank you very much for your attention, and I am happy to take your questions.
Thank you very much, Dr. Odler, for this amazing presentation. Honestly, with all the new data, with the very well structured, let's say, review of the existing literature. The people who are still connected, do not hesitate to ask your questions in Q&A. A lot of the questions actually were already addressed during the talk. And I wanted to maybe kick things off with a few questions of my own, the time that people add a couple of questions in the Q&A. I was wondering about the induction treatments and the fact that you said the combination of rituximab and cyclophosphamide for severe disease could be an option potentially for rapidly putting a patient in remission. What is your threshold, let's say, for the severity of the disease? At what point would you really do the combination?
This is a really good question, because if you take a look at the guidelines, that this cutoff of serum creatinine of 3.4 milligram per deciliter is recommended in most of the cases. But in the real life, this is not the case, because at one day you have a creatinine of 2 and the next day you have a creatinine of 5. So it's quite in the case of rapid progressive glomerulonephritis. What we do in our clinical practice, that we take a look at the kidney biopsy. And if we see several changes and a high level of activity in the kidney biopsy, then we consider the combination therapy. And to be honest, in most of the cases where kidney involvement is present, then we use the combination therapy. Otherwise, if there is a mild involvement in the kidney, but you see external manifestations, then rituximab monotherapy can be used as well. This is also an important question if you're considering plasma exchange, because we also use it if we see high activity in the kidney involvement, also in the kidney pathology.
Great. And actually, as you mentioned, the new avacopan data and the fact that we do spare steroids quite rapidly, I was wondering on the monitoring side of things, when we put patient in remission, well, some patients, when they do start a new flare, it is quite clear they're going to have their ENT manifestations, they're going to have their lung, you see them, you retreat quite quickly. But on those patients who have a more renal disease that is on the first line, and they suddenly will come with a rather severe renal disease in their flare, do you have any strategies for monitoring them regularly when you spare steroids? Do you do monthly urine sticks or something like that to systematically monitor someone for the potential flare when you do rapid corticoid sparing?
Yes, I understand the question because there is a bit of fear in the heads reducing glucocorticoids.
Are we treating the patient or are we treating our own anxiety?
Yeah, so I do the control of the patients independently of glucocorticoid shrimps. So I reducing shrimps, I mean, because if we use avacopan, what we learned from the advocate trial is that you can stop it because you have to think about the pathophysiology of the complement system. Then you can earn the same reduction of inflammation if you use complement inhibition, if you would use glucocorticoids as well. What I do in the clinical practice, at the beginning, we control our patients on a very, very tight basis. So that means they are coming to us every week to check the proteinuria, check hematuria, check the kidney function. And then after 2 or 3 months, we extend these intervals to 1 month. And after 6 months, if they are stable, then you can extend this interval to 2 or 3 months accordingly to the patient characteristic. It is different, because some patients have a relapsing disease. They are PR3 positive. We know that we have to control them more closely because there is a chance that higher chance for relapse. In the case of MP or ANCA, this is not always the case. So we can consider the controls in a higher intervals as well. So I would say it should be individualized. It should be not based on the glucocorticoid dosing, but based on the clinical characteristic of the patients. And you shouldn't be afraid about reducing glucocorticoids. If you do that, then you can still use the Pexivas schema or the Lowas schema. They are also quite good. We do it often. So actually, we use the Pexivas dosing scheme if you don't use avacopan.
Fantastic. And speaking of avacopan, I see a question in the Q&A. Thanking you for the talk and saying that in 2024, when would you actually consider avacopan when it is available?
So at the moment in Austria, we can consider avacopan in patients with comorbidities where the use of glucocorticoids would be a problem. For example, obesity, osteoporosis, high infection risk, whatever. So there is a limitation because it's still an expensive drug. So this is the first step. On the other hand, in the case of severe kidney involvement, we try to use avacopan in almost all the cases because we are more focused on this so-called hit hard and early approach. So that means try to reduce the inflammation from different sides as rapid as possible. So I would say if there is a severe kidney involvement or lung hemorrhage, then you should think about avacopan. But of course, you should have to think about the data from EMA and FDA, what they are saying.
And speaking of treatments, I see another question in the Q&A asking about different B-cell depleting treatments. The question is about comparing rituximab with obinutuzumab.
Yeah, this is a very important topic at the moment. Obinutuzumab will be an important treatment in lupus nephritis as well. We saw the press release some weeks ago that there are positive results in the case of lupus nephritis. In the case of ANCA-Associated Vasculitis, it's not so clear. There are, if I know it correctly, 3 running trials investigating obinutuzumab, but they are all quite small trials. I don't know whether it will show a benefit as compared to rituximab, because rituximab works quite well in ANCA-Associated Vasculitis. So I think there will be a difference as compared to lupus nephritis because the pathophysiology is quite different. And Yeah, I think
Okay.
it will be an extra option, but I don't know whether it will be better as rituximab. We will see the studies. One is in Cambridge, so I saw some. I saw the design at the beginning. That was quite interesting. I can say anything now, but it's interesting. Yeah.
Fantastic. And speaking of various treatments, I see another question about the role of IVIG therapy in ANCA. What would you recommend what is the literature around it?
Yeah, this is a very, very good question, to be honest, because I think there are two different aspects that you have to consider if you are thinking about immunoglobulins or IVIG. The first thing are the infections, because if you have patients with recurrent severe infections, with high level of a deep hypogammaglobulinemia or extended hypogammaglobulinemia, then you should use it. So in these cases, we contact our immunologist and we are managing our patients together, and we give in most of the cases IVIG if it's possible. On the other hand, there are some smaller studies in the literature as well. I think there is a small study published 1 or 2 years ago in AGKD that showed that the use of IVIG can be associated with a lower relapse risk as well. And there are some running bigger studies on this question at the moment. So it will be also quite interesting. In the case of severe infections, you should use it as an additional option. If you need a rescue therapy or if you don't have any other options, then you can think about it.
Great. I see another question about EGPA. Actually, in EGPA with cardiac and neurological complications, what would you recommend as a first line apart from the IV pulses of prednisolone?
Can I be honest? This is something where I don't have the expertise because we don't see so many EGPA patients. As approximately 15-20% of the patients have kidney involvement, and I saw a very few number of patients. So I don't want to say anything if it's okay. I think you have more expertise with these patients, as you mentioned.
I would say indeed in this talk, we're focusing a bit more on the renal aspects. It's a whole chapter of its own. The EGPA definitely. There are some interesting new data coming on in the next couple of years, I think, with the new trials in that side. But indeed, the IV pulses are definitely on the first line, but on some patients, rituximab could definitely be used as well, depending on the profile of the patients, of course. But focusing a bit more on the renal aspects, the next question says, when do you consider taper or hold maintenance therapy in ANCA end-stage renal disease patients? When to consider renal transplantation in ANCA-related end-stage renal disease?
It's also quite a good question, because if the patients are on dialysis, then you don't need extensive immunosuppressive treatment if there was only renal involvement. You should consider maintenance treatment if there is an extended external involvement. So it should be individualized as well. If you are considering kidney transplantation, you can do that and you should do that. It's important that the patients are on fully remission. It should be the case for at least 6 months before listing the patients, and that should not be a problem. The recurrence rate after kidney transplantation is relatively low, so this basic triple immunosuppressive treatment that we mostly use in kidney transplantation seems to control the disease quite well. So we don't really see recurrence of the disease after kidney transplantation.
Fantastic. The next question I see is that, do you have any preference between cyclophosphamide and rituximab for more granulomatosis form of the disease, such as tracheal stenosis or orbital pseudotumors? What do you think of on that side?
I mean, if there is less severe kidney involvement, then I prefer rituximab. You always have to consider if you are you are using rituximab, that it needs time to work. So the B cell depletion needs up to 4 weeks approximately. So you should use it in your patients where the kidney or any other organ involvement not so severe. This is a bit difficult to define, but if you see a less severe disease, then you can consider rituximab as a monotherapy. If you don't want to use combination therapy because you are afraid of the complications, then I would prefer cyclophosphamide in more severe disease.
Fantastic. And I see a last question in the Q&A saying, do you think the success rate of treatment could be affected by the ethnic origin of patients?
This is also a very good question, but I can't recall any large studies that showed any differences by ethnic groups. So I don't think so that there is difference, but I am very, very careful saying this comment because I can't recall studies on this.
Fantastic. Well, thank you very much, Dr. Odler, for the fantastic talk. It was very informative, and I think the general internist and all specialties very much benefited from your talk today. For all the people who are still on the call, I just want to announce the next webinar of the EFIM Young Internists that will be held on December 12th at 7 p.m. That one will be talking about perioperative management of patients with endocrinopathies. And we're going to keep these webinars coming, and they will be uploaded on the YouTube channel of EFIM normally, and it will be also available on EFIM Academy. Do not hesitate to send us your recommendations, your comments, and thank you very much, Dr. Odler, again, for being with us tonight.
Thank you for the invitation. Have a nice evening.
Have a great evening.
Thank you.
Thank you.
Bye-bye.